Good afternoon, respected chairpersons and dear participants. At the outset, I would like to thank the organizers and the APSI for making me part of this exciting hand module. The topic assigned to me is radiology and electrodiagnostic investigations. So this is a very long topic, but I would like to only highlight the key points so that the participants can go into this module with some working knowledge of both these aspects. So what are the indications of radiology? We all know trauma with suspected fracture or dislocation, foreign body, or investigation into joint pain or deformity, rheumatoid arthritis or osteoarthritis. So standard views are standard frontal PA view or oblique PA view, lateral views and special views. So the frontal view will provide us very good visualization of the metacarpals, phalanges, radius and ulna, and it is excellent view to look at metacarpal or phalangeal fractures and also early signs of rheumatoid arthritis or osteoarthritis. So what we cannot view clearly in the last view is the adequate visualization of the thumb, especially the CMC joint level. So we can use the oblique view to have a very good visualization of the CMC joint as well as have a profile view of the MP joints. This gives somewhat three-dimensional rendering to otherwise two-dimensional investigation. Lateral view, as obvious, is at the 90-degree to PA view, and it demonstrates all the carpal bones which are overlapping. We can come to know any displacement of the fracture segment, in which direction they are moving. We can also come to know where exactly how deep the foreign body is in this particular view. So another thing to notice is fingers are in progressive degree of flexion. So each middle and distal phalanx is projected separately and we can individually assess them. Also, the thumb is projected in a frontal position. For assessment of carpal bones, we again will require at least three views: posterior, anterior, lateral and oblique. So you can see the first carpal row will form two parallel arches, first arch and second arch. And then the capitated hamate will, proximal surface of these two bones will form the third arch. So these three arches are usually parallel in normal scenario. And any fracture of the carpal bones will always alter these arches except for some fractures of trapezium and trapezoid which cannot be seen in the earlier view. So they can be well visualized in the oblique view. You can see in this the joint between trapezium and trapezoid can be well visualized. So oblique projection is a better projection of these two bones. So any interruption of these arches could be secondary to fracture of carpal or dislocation of any bone or any complex injuries like in this case. You see, the lunate is tilted and not articulating with any of the carpal bones. So lateral view will show dislocated lunate and it is rotated 90 degree in a palmar direction. So we can also have a better view of scaphoid by doing maximum ulnar deviation of the wrist. So what happens is the scaphoid will appear elongated and we can visualize the cortex adequately as well as see the trabeculae, and any fractures which otherwise would be missed are not missed. For hamate also there is a oblique view, but this is not very practical view. You see there is a small fracture here which is not very clearly visible. Of course CT scan is better for hamate bone. You should also have some idea about the motion views. So also called as instability series. Basically you want to know whether there is any ligamentous injury using only the x-rays. So most commonly done views are posterior views with maximum radial or ulnar deviation or with the maximum extension or flexion. So you can see this appears normal, but once you do the radial maximum radial deviation, this space opens up. So there is a scapholunate dissociation and you can investigate it further or treat it accordingly. Similarly, metacarpopharyngeal joint or thumb can be analyzed by using instability series. Of course, then it has to be compared with the opposite side because some people will have hypermobile joints to begin with. So what is the role of computed tomography? It has the merit of providing us with primary images in all the planes and also multiple axial images, and we can have sections as thin as 0.5 to 1 millimeter, and they are very important for diagnosing any anomalies of carpal bones or any injuries to those, and we can also have three-dimensional rendering. So like in case of non-displaced fracture of scaphoid and the person happens to be a high performance athlete and you want to know it on the same day, what sort of investigations you should undertake, and x-ray is not revealing anything, you can go ahead and do a CT scan. You can see a hairline fracture and you can treat it appropriately. Similarly, you can follow the scaphoid fractures with CT scan. You can see a healing fracture line here and here, and even in case of non-union, these things can be easily seen using a CT scan. The fracture of the hook of the helmet, which are so difficult to see with X-ray, can be easily visualized with the CT scan. This is the normal hook of the helmet. This is the fractured hook of the helmet. Fracture of capitate and body of helmet or even dorsal dislocations can be easily visualized, and the three-dimensional relation can be assessed. So to summarize the computer tomography, it is good for small avulsion fractures because of overlapping nature of the carpal bones, and complex fractures and dislocation are usually helped by CT scan, and also we can have a three-dimensional rendering. Ultrasound is not very commonly done, but it is very suitable for detecting fluid collections, say in case of ganglion cyst or of wrist and the hand. We can also visualize superficially located tendons, so we can diagnose tendon ruptures or partial injuries, and ligamentous injuries like ulnar collateral ligament injuries in gamekeepers or skiers thumb, synovitis can be diagnosed. So, but the drawback is since ultrasound is not going to visualize the bony structures, so ultrasound is extremely operator dependent. So making an accurate diagnosis remain consistent even in the hands of those who are regularly doing it. So ultrasound studies of hand and wrist are usually infrequently performed in majority of the centers. What is more commonly done is magnetic resonance imaging, and this has brought in paradigm change in hand imaging. So with the proton density weighted images, you can see all the carpal bones, the bone marrow in the carpal bones is nicely visualized, and in case of T2 weighted images, you can see the articular fluid between the carpal bones and as well as the hyaline cartilage. So any injury to these structures can be visualized in T2 weighted images. Say in case of triangular fibrocartilage tears, you can see the tear in this and this picture. Again, scapholunate or lienotricotal tear can be easily seen as opposed to the normal intercarpal spaces. Similarly, ulnar collateral ligament tear of the thumb, that is Steiner's lesion, can be visualized using a MR. Tendon lesions are not commonly assessed with MR, but they can provide us the exact idea of the end of the detected proximal segment, which could be helpful in planning the surgery. In carpal tunnel syndrome also, there is anterior bowing of the transverse carpal ligament, edema of the median nerve, as well as there could be any thickening of the synovium can be seen, and you can see the pre-op and the post-op view in which the nerve has opened, the carpal ligament has been divided, and nerve has opened up and edema has decreased. Similarly, avascular necrosis of carpal bone can be diagnosed like this in case of scaphoid, or box disease, that is necrosis of the lunate. Tumors also, MR will excel in diagnosing tumors. It will give us precise location, extent and relationship to the adjacent muscles so that we can plan an excision. We can also typify the tumors, like lipoma will enhance on T2 weighted images and ganglion cyst will enhance on T1 weighted images. Similarly, malignant soft tissue tumors will show infiltrative nature. So a broad algorithm. So whenever a patient of acute wrist injury will come, you can go ahead with the radiograph. In case the diagnosis is clear, go ahead and treat. In case you find there is a complex injury, it is preferable to do a CT scan. In case radiograph don't show anything, you suspect some injury, you should go ahead with special views. They also don't have, go ahead with CT scan. So this is broadly you should do, and usually CT scan will give you good assessment of the bony injuries. What it does not give is the soft tissue injuries, so they can be found out by using an MR. In case you suspect there is some injury to a ligament, it's better to go ahead with an MR. So second part is electrodiagnostic studies. So broadly these are nerve conduction studies and needle electromyography. So what is a nerve conduction studies? Primarily it is the electrical stimulation of the nerve which will initiate an impulse. So this will travel along the nerve, so we can objectify the lesion and precisely localize where is the site of maximum involvement. So these are recorded as CMAP, that is compound muscle action potential in case of a motor nerve, and SNAP, that is sensory nerve action potential in case of sensory nerve. This will permit assessment of function in motor and sensory nerves. So only thing you should be aware is the timing of getting these studies. You see, motor axons will remain excitable for up to 7 days after injury, and sensory nerves with up to 11 days. So it is preferable to time these studies after 14 days of injury. And this is the classical waveform. We'll study the parts. The amplitude is the height of evoked response on stimulation. So it is sort of a quantitative measure of number of axons which are firing. So this is rather the only NCS component which is having direct relationship to the clinical symptoms of muscle weakness, say sensory deficit. As these symptoms improve, the amplitude will also improve. Second is the duration. It is the time interval during which the evoked response is happening. It reflects the conduction rate of the impulses. Latency is the interval between the moment of nerve stimulation and onset of CMAP or SNAP. So using these two parameters, we can calculate conduction velocity. So motor nerve conduction is measured. We have stimulating electrode which can be in axilla, elbow, at the wrist region, and then there is active electrode which is over the muscle belly, and there is a reference electrode which is over the tendon, and the recorded potential is called CMAP. So only thing you should know about CMAP in this is that up movement is negative and down movement is positive. So amplitude, as mentioned previously, reflects the number of muscles that are firing. Duration is the initial reflection at the time of the first baseline crossing. Latency will represent three things. One is nerve conduction from the stimulation site to the neuromuscular junction. Second is the delay across the neuromuscular junction, and third is depolarization of time across the muscle. So all of three of these will add to the latency. It is the measure of fastest conducting fiber which will cause initial deflection. For calculating the nerve conduction velocity in motor nerve fibers, two stimulation sites have to be used. The conventional sites are wrist, elbow, and axilla. So we stimulate at different points, calculate the difference in latency across all these 3 points, and that is divided by the distance between these 2 points. Just to see, this is the stimulation at the wrist level, this is at the elbow level, this is at the axilla level, and that's the up point. And we calculate the distance between these 2 points and calculate the nerve conduction velocity, and that will give us some idea of the site of the blockade. This is the median nerve motor study in action. This is at the proximal wrist level. This is at the second point at the elbow level. Ulnar nerve study, motor study, proximal wrist level and the elbow level. Sensory nerve conduction is usually opposite of motor nerve conduction. Here we stimulate the nerve distally and record proximally. So for each stimulation, we'll calculate onset latency, peak latency, duration, and amplitude. So snap amplitude of sensory nerve depends on number of functioning large myelinated axons which are present, and snap conduction velocity will be calculated by dividing the distance from the latency. So only difference is conduction velocity in sensory nerves can be calculated with only single stimulation point, because there is no transmission delay across the neuromuscular junction like in case of motor studies. So this is the way we'll record, we'll stimulate the nerve, calculate the latency, calculate the distance, and come across the nerve conduction velocity in sensory nerves. Median of sensory study in action, ulnar nerve sensory study in action. So important basic patterns. So we want to know whether there is a axonal loss or there is only demyelination. So in case of axonal loss, most important is reduced amplitude of CMAP or SNAP, whatever you are measuring. But the conduction velocity will usually be within 75% of normal, and distal latency will be not more than 130% of the normal. So this is a classical pattern of axonal loss, as opposed to demyelination injuries, in which there will be marked slowing of the conduction velocity. You see, in demyelination, as you move proximally, the conduction velocity decreases significantly, and as opposed to a normal study. So it is said that conduction velocity which is slower than 35 meter per second in upper limb or 30 meter per second in lower limb signifies the demyelination. The last part is the needle electromyography. So primarily we are inserting the stimulating needles and measuring the electrical activity. Primarily these are insertional activity, spontaneous activity, muscle unit action potential, motor unit recruitment and interference patterns. Insertional activities, when you are inserting the electrode, there will be some activity. So this is a measure of muscle excitability. So when the muscle is denervated initially or it is in the inflammatory process, there will be hyperstimulation at the time of insertion. But as muscle undergoes fibrosis or is totally inexcitable, there won't be any insertional activity. Then there are spontaneous activity. Muscle usually will be silent after, in case you are not moving the needle, the stimulating needle. So, but in case there is abnormal spontaneous activity, namely persistence of activity outside the end plate zone, or any activities lasting for more than 3 seconds on EMG recording. These are signs of spontaneous activity, and classically these are fibrillation potentials, positive shaft waves, or fasciculation potentials. So fibrillation potentials are spontaneous discharges from a single fiber, and they can be diphasic or triphasic. Positive shaft waves are initial positive spikes followed by a negative potential which is much lower in amplitude. These are again signs of denervation. And the last are fasciculation patterns. They could be biphasic or triphasic, but per se they are not abnormal provided unless they are accompanied by fibrillation or positive shaft waves. So MUPs is another way of finding out the status of the muscle. So during voluntary activity, what happens is this is a polyphasic recording, phase 1, 2, 3, and long duration recording lasts for 2 to 15 seconds, and it is a large amplitude recording. So among all these, duration is a better index of motor unit integrity. So what will happen in case of muscle injury, denervated muscle or recovering muscle? So as the patient tries to flex more on, that is tries to cause voluntary contraction, so there will be spatial recruitment. But in case there is no recovery, the surviving motor units will only fire, and there is no spatial recruitment, but there will be temporal recruitment, that is the firing rate will increase. So this is the normal recruitment in interference pattern. This is a neuropathic muscle because there is no all the muscle units are not firing simultaneously. So this is the picture in neuropathic muscle. This is of course confusing. Just a slide to take care of all this confusion. So in normal muscle, insertional activity is normal like this. In injured muscle, it is increased. Spontaneous activity none in normal. Fibrillation or positive shaft waves in injured muscle. Motor unit action potential is classical in normal muscle, but extended in a neurogenic lesion. Interference pattern will be full in a normal muscle, but reduced, but with faster firing rate in a injured muscle or a recovering muscle. To summarize, in case of neuropraxia, there will be no or sparse fibrillations. Normal MUPs which are firing at rapid rates will reduce interference pattern. Axonotomies will show fibrillations will reduce interference pattern and decrease firing rate of MUPs. In neurotomies, there will be profuse fibrillations with no voluntary MUPs. So how does the timing of study helps us in diagnosing? In initial study, which is done at 2 to 4 weeks, it will distinguish predominantly demyelinating lesion from a substantial axonal loss lesion. And it will also assess the extent of axonal loss. There will be reduced CMAP amplitude and number of MUs recruited with maximum effort. A follow-up study at 3 to 6 months will document the extent of reinnervation, which is of course timeline based. In case there is partial neurotomesis also, there could be some growth in some recovery and in the distal part, and it will the study at 6 to 12 months will document the reinnervation at a greater distance from the injury site. So the limitations of electrodiagnostic studies is it will assess only the large myelinated axons which are transmitting position, vibration and light touch, but not pain and temperature. And timing of this study is very crucial. And a single study will not give you much of an idea except for typifying the lesion. Only serial studies are of some value in hand injuries. So I think in short, this is all about radiology and nerve conduction study. Thank you.